Okay, so we have been treating acne scars since a long time, and because of the variable kinds of scars that are there, the various in each patient there are multiple types of scars. So never has it been that one treatment is enough for all the scars. So each time you have, most of the times you have to combine treatments for the patients. We see various kinds of scars in our practice. There are post-inflammatory hyperpigmentation, like you can see here. Post-inflammatory erythema is also very common. There are box scars, both superficials and deep ones, and then there are ice pick scars. As we can see in this, many rolling scars are also seen. Rolling scars that are often combined with something linear here. If we can see, that's linear boxcar scars, if we may call them. And then there are linear tethered scars, which especially when the patient animates his face is visible quite a lot. Boxcar scars can be seen here, some ice pick scars. So in each patient that we have, always there is a combination of scars, and that's very important to understand what the kind of scar is, what the anatomical level of the scar is. So if we go into the microanatomy of our skin and understand where that scar is, then it becomes very intuitive and easy to treat them. A very uh, a very nice infographic, one of my most favorites, which I also use while explaining to patients, is this one from acne.org, a wonderful site. It talks about the different types of scars that are there and the various options that we have in terms of treatments for acne scars, and then it's graded according to the effectiveness. Green is effective, yellow is less effective, and red is ineffective. If we go on one by one, so for lasers, that's CO2 and erbium YAG laser, that's ablative CO2 and erbium YAG, or fractional CO2 erbium YAG. They're great for rolling scars, shallow and boxcar scars. So the way they work is basically either by burning or heating the skin. In ablative, you burn it. In non-ablative lasers, you basically heat it, do coagulation. Not very effective for ice pick scars. Then we talk about the augmentation or the fillers. So when we are talking about fillers, fillers are the most effective in rolling scars. So we see, once we have done subcision or just inject a needle and try to create space from within inside, that's when augmentation, that's rolling scars, and to an extent in boxcar or deep boxcar scars also. So once you connect the boxcar scars into a converted into a rolling scar by feathering the margins, then again they become rolling scars, and then in those cases augmentations is effective. Augmentation or fillers can be of three different types, as I understand it. The first and the long term one is basically hyaluronic acid fillers, that usually stays for about a year, and the year and a half. But because it also stimulates collagen formation, in many times you don't have to repeat the treatment. The second or third type of it is fat and biofillers. So both fat and biofillers are not very long term. Fat does not survive if injected into the dermis per se, but because once we do the subcision, and instead of waiting for the hematoma to form, if we let the fat sit in there, it creates a structure over which the new neocollagenesis will take place. So in that way it's very effective. It also contains adipose derived stem cells, which again help in new creation of the tissues. If someone is not as affording, or you don't want to do an invasive procedure like fat transfer, you can of course always take biofillers that take plasma and coagulate it, and the gel that is formed, you can use it instead of, say, fat or hyaluronic acid fillers. Even biofillers will stay for about 15 days to 30 days in the dermis, but what it will do is it will again create that structure over which the new tissue will form. Subcision combined with biofiller is one of the most recent, and a treatment that I have started doing quite a lot, and it's giving wonderful results. So that's something that can be tried at a very low budget also. In terms of subcision, again, we know subcision is bi-level, so it can be either in the dermis, as we can see in this, or it can be done at this level, in the subdermal level, as like I'm pointing here. In this level also, it can be either a needle, or we can use a cannulas. So cannulas that we use for fillers, those can be used. It's known as blunt subcision. Or newer devices like the Taylor Liberator can be used, which are semi sharp. So they're not exactly sharp like a needle, but they have a pointed edge, which when inserted into the skin will lead to that bi-level subcision. Punch excision, punch elevation, good for boxcar scars. Small punch excisions are good for ice pick scars. Otherwise, in rolling scars, they usually do not have any effect. Also, punch excisions do require some amount of skill on part of the doctor. If you're not good, if you don't have that skills in order to suture properly, the results are not as great. So practicing the suturing part is very important in order to get punch excision results. TCA cross, good for ice pick scars and for shallow boxcar scars. This is how it works. It basically stimulates the fibrous skins in the dermis after going there, so it burns the skin above. The epithelium is ablated chemically, and then the skin below it, that's the fibrous cells, are stimulated in order to create more collagen and elastin. So good for ice pick scars or shallow boxcar scars. Then I've covered fillers, I've covered subcision, punch excision, chemical peels to an extent in ice pick scars or shallow boxcar scars if they are deep. TCA cross I spoke about. Micro needling is something we can definitely do. Derma pens, there are derma pens from a wide range of budget. It can be as derma pens come for as cheap as say 5,000, 10,000 rupees, and then they also go up to 2 lakh rupees. That's the official derma pen. Each one has its effects. Usually the ones that are expensive like collagen pen or derma pen have better results. That's because of the strength and strength of the motor that's there, and the needles go much deeper. These are good for the rolling scars and the boxcar scars. In terms of fractional radio frequency, there are various devices which are available, again good for the rolling scars or boxcar scars. So anything that will stimulate the dermis is going to help in rolling and boxcar scars. And in ice pick scars, as we can see, TCA cross and punch excision are the two most important treatments that usually give results. I'm going to discuss two patients. In them, the treatments that I've done to achieve these results. So if we can see here, this is one patient who has had rolling scars, multiple rolling scars, and a few tethered scars in this area with volume loss. So he has again multiple. He doesn't have many ice pick scars as such, but yes, volume deficit in this area, and you can see deep rolling scars here, here. So this patient, the way we have treated him is we have done talar liberator, that's a deep plane subcision, subdermal, and we have done subdermal fat autologous micrograft transfer, and also intradermal subcision plus micrograft transfer, and then done fractional CO2 on him. And these are the results that we could obtain after 2 sessions of combination of these treatments. See, if you can see again, this areas where the rolling scars are there, and we can see subdermal atrophy also. So fat atrophy is also there. So placing the fat after the subdermal subcision has given this results. I'm going to play this video now in which we see the whole procedure, what all has been done. Talar Liberator is the first procedure that we've done in him. Yeah. So first in Talar Liberator, what is done is, because it's a semi-blunt device and the device is large, the gauge is around 18 gauge. We usually do tumescent anesthesia because it's subcision at a subdermal level. When tumescent anesthesia is used, the skin is lifted above the smash layer, so it helps in compressing the blood vessels below the in the smash layer and below the skin, and also lifts it up from the nerves. So the damage that's caused is quite less, and in 2 to 3 days this swelling also settles down quite nicely. Actually the next day itself it's quite less, the patient is comfortable, and the anesthesia in itself also makes the procedure quite comfortable. What I'm using here is a tumescent pump and a 22 gauge spinal needle, so that less amount of pricks have to be done. Post that, insertion site is made with a 11 number blade, a stab incision is done, and this is the Talar Liberator that's there. Like I had shown in the photo, it's a tri hook thing. Once inserted inside, it's not sharp, it's semi sharp, and then once it goes inside with a to and fro motion, we release the skin and the fibrous scarring that is there from below the skin, we lift it up. So this indication is basically for rolling scars that are there, in which we can see that the surface of the skin is up and down. So especially when the patient animates, we can see that there is fibrous scarring below the skin. If there's only dermal atrophy and there's no subdermal atrophy, no subdermal fat atrophy, then this procedure obviously won't help. But most of the patients do have some amount of subdermal atrophy, especially if they have had cystic acne. So from the same entry point, we go in and separate the scarring. The level at which I am is immediately below the dermis. So if you can see at these points, we can actually see the tip of the device that's there. And because of the tumescent anesthesia, I'm not harming much of this mask layer. The other hand is acting as a vision, so I can feel where the cannula is and then accordingly direct it and also target the scars that are there. Post that, we just roll over and remove as much of the fluid as we can in that part, so that not much fluid stays inside post the surgery. But we don't try much. In a day or maybe maximum 2 days, that fluid goes off. Then the same patient, we are taking fat. So I'm injecting tumescent anesthesia, getting fat out of his abdomen. We can see fat harvesting being done here. This is a 60 ml syringe which has a syringe lock present above it, and it helps in making the fat harvesting procedure is easier. Once that is done, we harvest the fat. Again, in fat harvesting also, I use the other hand as a guide and to feel where the cannula is. This part that I'm doing is intradermal subcision, to and fro motion. I am in the dermis. The needle is a 20 gauge needle. I am in the dermis. I am injecting fat. So this is microfat. This is not nanofat. I'm injecting microfat in the dermis. Like I showed in the subcision slide and the filler slide, what I'm doing is I'm subcising intradermally, and instead of just leaving it like that for it to fall upon itself or waiting for the hematoma to form, I'm injecting the fat into this. Once the fat is injected, it creates that separation, and over time the fat gets reabsorbed and new tissue forms over this area. Because in this patient, the areas that I have marked also had a lot of subdermal atrophy, that's fat atrophy below the skin. I have also injected. So if you can see here, this post injecting in the skin, I have also used a cannula. So I go below the skin, and below the subdermally, I am also putting microfat. So whatever dermal atrophy that he had, subdermal atrophy that he had, that depression is filled out with his own fat. So in the before photos, if you had seen, he had a very depressed part here. Post the fat injection, his face looks fuller and more contoured and younger. So just to recap this patient again, this was the depression that I was talking about in this patient. These are also the areas in which we did the subcision and filler and the fat filler and fat. So overall, this is the improvement that we got in just 2 sessions. One session of the whole Taylor Liberator fat thing, and one more session later of a fractional CO2 plus PRP treatment. In just 2 treatments, this is the improvement that we can achieve over a period of say 6 to 8 months. So the patient doesn't have to come again and again for fractional CO2 treatments. We just do 2 or 3 sessions and we get a good improvement in the patients. The same patient from the other side. The second patient that I'm going to show today is this patient. Again, the case has multiple box scars and bridge scars. So in the next photo, I'll show all of these submarine like scars that we can see go on to the other side, and there's a lot of bridging that's there. So even though it's not appearing too much in the photos, when she touches her face, there's a lot of unevenness, and there are hypertrophied areas in it. So I'll show how those bridge scars are treated, and also how the box scars that are there here, they also show how the surface is ablated with a fractional CO2 laser to make it all smooth. We can see some amount of hypopigmentation here. This is 2 or 3 months post that, but now when the patient has come for follow-up, it's pretty much normal, so not much to worry. So this is the bridge scar that I was talking about, and the patient had almost 20 of these on like combining the two sides together. So a lot of them. So whenever she used to feel her face, it was a very hard nodular feeling that she used to have because of the hypertrophic bridge scars, and this is what we release quite a lot. So on the photographs is not as much visible. Yeah. So I'll show how to open these bridge scars, how to do the ablative laser for the CO2s. So if you can see, she had these multiple bridge scars. What I do is I just put a plain forceps in there and open this up with a 11 number blade. Once these are opened up, I cut them off, and most of the times the area beneath it is raw. If not, I make it a bit raw with the blade itself. As you can see, one more bridge scar that's there. I open this up from both the sides, so I cut the bridge from both the sides, and below it whatever it is left open. While doing the fractional ablative CO2 for the feathering of scars, I also ablate the base of these bridge scars, so that new tissue, whenever it's formed, has a whole uh, gets formed together on the whole skin. So you can see I hold the bridge part and then remove it with the 11 number blade. So this is done for each of the scars. Then again the same tailor liberator procedure. I have fast forwarded this because I've already shown it in the previous video. First tumescent anesthesia is given, and then the tailor liberator is put inside. The tumescent anesthesia here is 0.001%. So in 500 ml of normal saline, we usually put 20 ml of lidocaine, so that goes to about that percentage. Also add adrenaline and sodium bicarbonate. If you can see here how this other hand is trying to visualize uh, where the cannula tip is and removing the scars. So both the hands act in synchronization to do the procedure. Once the procedure is done, then again we do the fat grafting for her and repeat the same intradermal subcision along with injection of the microfat in the dermis. So again, the common understanding is microfat is injected below the dermis, subdermal, but here what I'm doing is injecting it in the dermis. The idea being it acts as a scaffolding for the neocollagenesis that happens. This is a conventional CO2 laser, 500 micron tip, energy is 24 millijoules, and what we are doing basically with it is whatever the borders of the bridge scars or the box scars were there, I'm just ablating them so that they get smoothened out, feathered out. The same thing, I'm just with a free hand painting it so that the borders get feathered out. These are other 2-3 videos that I have of the procedures. I'll just share them once just to cover maximally. This is TCA cross. I'm using a toothpick and placing the trichloroacetic acid. I usually use 50% trichloroacetic acid, but 100. Some people also use 100% or are fine with it. I've just noticed a higher chance of hypopigmentation with it, so I prefer using the 50% trichloroacetic acid. In most of the patients, we also do fractional CO2. Depending on the type of scars, the parameters usually change anywhere from 50 to 100 millijoules is the power, and the density may range between 50 and 100 dots per square centimeter. So that gives a area coverage of around 8 to 15%, depending on the density that we use. Post that is done, post the fractional CO2 is done, we either inject PRP, or if fat is taken, then we also prepare nanofat out of it and inject it also, and also apply it over the fractional CO2 marks as a drug. So it basically acts as an intralesional drug delivery. We just apply a mask out of it and let it be for 20 minutes. So whatever the adipose derived stem cells that are there in the nanofat should go inside and help in the healing and neocollagenesis. I'll just share a few results, so just let me know if I'm overshooting the time, and I'll end this. But again, I'll just share a few results of similar procedures. Again, most of these patients have been done with 1 or 2 sessions only, and the results are post 3 to 4 months of the last session. In this patient, what we have done is tailor liberator. So if you can see, we have done tailor liberator and fat and CO2. If you can see all the scarring that is there, especially superficial but also deep rolling scars, and overall because of the tailor liberator and fat, the face, which is very depressed in the scars area, rises up and gives a nice appearance. The same patient on the other side is another patient in which we did tailor CO2 and fat. You can see the scarring in these areas. Pardon me for the lighting, it's a bit different, but yeah, the difference can be noticed. In this patient again, what we did was biofillers, tailors and CO2. So not in all patients we need to do fat. Biofillers is something again that is very helpful and quite easy to do. So you just do a subcision and a biofiller. In this patient, of course, we've done Taylor's Liberator, but only a subcision, a biofiller and CO2 also gives quite nice results, is what we have observed. The same patient on the other side. This patient is post Taylor Liberator, fractional CO2, subcision and biofiller. So again, another patient with no fat that is done. This is only Taylor Liberator, fractional CO2, subcision, biofiller. Subcision is intradermal, and then instead of putting fat there to as a scaffolding, we use biofiller as a scaffolding here. The same patient, the other side. Another patient post fat grafting and subcision. So in this patient, no Taylor Liberator was done, just fat grafting and subcision. This patient, Taylor Liberator, fat and CO2. You can see the improvement in the volume and in these rolling scars. Another patient with rolling scars and the improvement that we can see. She has some pimples which have come later, but yeah. This patient again had post-inflammatory erythema and rolling and box scars, and post the treatments that we did, a combination. So the combinations usually depend on what type of scars there are. Like we saw in the first diagram that was there, depending on the scar and depending on the techniques that you have, you can mix and match and do multiple treatments together, going from the lower side to the upper side. So first do the deepest treatments and then start coming up. That will help you combine and also give you an algorithm of how you should combine depending on your skills and the devices that you have. Another patient with quite deep rolling scars and post-inflammatory hyperpigmentation also. That's it. Thank you.
Yeah, Dr. Dhanraj, am I audible?
Yes, sir. Quite
yeah. So, very nice and interesting cases. The audience wants to know your trade secret, some which I will be asking you one by one.
Sure, sir. My pleasure. I'm here.
Yeah. So, what was that needle? If you can repeat, we would also like to.
What was
that needle which you were putting inside?
So that device is a Taylor's Liberator. There's Dr. Mark Taylor in America, and he's devised this device. It's basically a long stainless steel device. It's quite thick, about 16 to I think 14 gauge, not 16. So it's quite thick and quite strong. You just have to insert it from one point, and it goes right till the angle of the mouth. So from one entry point you can cover the whole cheek area and whatever adhesions are there below the skin. This is not intradermal, this is subdermal. So whatever adhesions are there subdermal are released. So especially when the patient smiles and all the scars that get increased, those are signs that the patient has subdermal adhesions. Those get released quite nicely with this device. It's Taylor's Liberator.
Where do you get these needles?
So you can just Google it. The website is Gateway Aesthetic Laser. That's Dr. Mark Taylor.
Okay.
Yeah, so on their website you can order it and they ship it to India. The cost is around 21,000 rupees. The last 2 years, it's almost 2.5 years now. 2.5 years back when I bought it, it was $300, $350. So I think should be the same. Some amount here and there, 20 to 25,000 rupees.
Like what are the advantages this has over our typical 18 gauge needle or say cannula?
So usually what I've observed is 18 gauge needle when we do, we are always in the intradermal level. If we go subdermally and try to do with the 18 gauge, the damage to the subdermal structures is quite a lot. There's a lot of bleeding and you can't do it in such a wide area. If you take a 18 gauge needle and try doing it in the whole area, the bleeding is quite a lot, and the damage is more, is what I have observed in my limited experience. With this, once you give the tumescent anesthesia, you just have to enter through one point, and then you're doing the subcision through the whole area. The healing is quite nice. There's only one patient who has got some mild hypertrophy, which was quite unexplained, but she also had some weight gain. But otherwise, within 1 or 2 days, the swelling also reduces and the patient is totally fine. There's not much pain also. Some patients have paresthesias, but that's it. So one is the ease of doing it. Tumescent takes maybe 2 or 3 minutes, and the whole procedure takes 2 or 3 minutes. So in 5 minutes, I'm in and out with one whole cheek side. So if there's an assistant who's preparing the patient and everything is done, then in 5 to 10 minutes you're done with one side. Which, if you're doing an 18 gauge needle, would take more time, I'm sure. And the damage is less because of the tumescent anesthesia.
Okay.
Yeah.
So interesting, very interesting and innovative things. So we had a very long session. We had our first part. We had some demo for our state Cuticon,
Yes.
followed by this Axi workshop.